Right, good afternoon, welcome. This is the meeting of the Lancashire and South Cumbria Health and Care Partnership Strategic Commissioning Committee. It's a formal meeting this afternoon. It's being recorded for transcription purposes. We've a number of members of the public who've registered their interest to join the meeting. Hello there, you're all very welcome indeed. Welcome your interest in our business. If I could ask you, please, on the protocols of these virtual meetings to keep your cameras and microphones turned off, and to recognise that the chat thingy down the side is part of the meeting. Things that people post in there are part of the meeting. So please leave that to members of the committee. I have apologies today from Jane Scattergood, from Samantha, and from Linda Riley. We come together at this time when the services across the health and care system in our patch are. Did Dennis just say his Wi-Fi is playing up, or his wife is playing up? Wi-Fi. Thank you, Dennis. We come together at a time. It's thrown me that completely. Sorry. At a time when the services that in the health and care system across our patch are under incredible pressure. Always is these first weeks in January, for those of us who've been around the block many times know there's always this post-holiday period surge in demand, and of course this year with the Omicron variant of COVID, those pressures are exacerbated. We're keeping on top of the numbers, of course, each day, looking for trends, looking for signs of are things still going to get more difficult, or are they starting to get better. We're looking at the number of cases, we're looking at the admissions to hospital, we're looking at the numbers of people being discharged from hospital. We're looking at, crucially, at staff absence rates, and we can't draw any conclusions about the changing the shape of the increased pressure trend lines at the moment. It's very tough, and it's going to continue to be tough for a period of time. Hopefully things will start to ease soon, but the response that we see from all parts of our sector, in primary care services, in mental health services, in hospital services, in community services, in social care, in our voluntary charitable organisation sector, the response is remarkable. People continue to go up and well beyond the call of duty. We're asking, making unreasonable in many ways demands of people, and they continue to rise to the challenge. And I want to recognise that at the start of the meeting, to thank people for the incredible job that they continue to do, and for members of this committee for the leadership you continue to provide on a day-by-day basis in this, which is making the difference between this us being able to respond in the best way that we can, which is what we're doing now. In view of that context, I'm not cancelling any regular meetings. We had an ICS board yesterday with this meeting today, but we are trying to focus the business down so that we only take up 1 hour of people's time in this formal meeting, recognising that there's so much going on and so many other things that you have to do. It requires a discipline from me in time management that I haven't always exhibited on a consistent basis in previous meetings, and it requires a focus for us all as members of the committee in concentrating right on the core of the issues. There's important business for us to do today. Some policy approvals, some connection with the close down of CCG report, and the important issues to raise from the quality and performance subcommittee, we're going to have to pack all this in with a really tight focus. We do this also in the context that the implementation date of the new integrated care board establishment. Can we go on mute? Thank you. On the integrated care board establishment and the end of the CCGs is now 30th of June rather than 31st of March. We would have been ready for the 31st of March. We now continue with our existing statutory and organisational structures to the end of June. I'm having separate conversations with the chairs of CCGs about how we manage this extended period. But the role of this committee is going to be vital in a safe and secure management of business as usual and transition to the new world, and we'll continue to operate now throughout that extended period. So there we are. I've not received any new declarations of interest or relating to any items on the agenda. If you feel there's one that you haven't declared, please raise it at the appropriate time in the meeting. We've got our minutes of the last formal meeting, which was on the 11th of November. Feels a while ago. We had a good meeting. Unfortunately, I remember at the last meeting I crowded out the performance report, so it's important we get an opportunity today for Catherine and colleagues to highlight any issues for us to be aware of. But all that was there on the action log, the two items there are proposed to close. Can I propose the adoption of the minutes of the meeting on the 11th of November and look for a seconder, please?
Formally second them, Chair. Thank you.
Thank you very much, Roy. Andrew, over to you.
Chair, thank you very much. And just to build briefly on your opening remarks, clearly we have returned to a level 4 national incident in relation to the pandemic in the middle of December. And therefore, I want to start really by paying tribute to our staff in the CCGs and the CSU who have made their contribution to some of the response that you summarised in your opening comments. So we've had staff who've moved their roles to support vaccine rollout. Some staff have moved to support general practice where there've been staffing absence, because that's one of our risk areas at the moment. And clearly over Christmas, New Year and into this first part of 22, we have a range of commissioning colleagues playing their roles in managing flow, discharge and other issues. So I would like to start by paying tribute to that. One of the exercises that we've planned to take place this week, again, is a multi-agency effort to try to maximise the flow of patients through our system. And I'm pleased to say that a number of us have just come from a meeting where at this point in the week, we are seeing improvements in the numbers of ambulance delays, in a reduction in bed occupancy levels, which is obviously helpful, a reduction in long waits in emergency departments. And for 3 days in a row, our hospitals have been able to discharge more people than they've been able to admit. Now, that is very striking in the context of everything else that we're doing. It is still very much about risk mitigation because our services remain under significant pressure. There's no way of covering for that, but I'm really pleased to report that's the kind of work we can do in our system when we work together, and it's a really great team effort. The other brief message I want to give, and then I'll obviously hand back, is just to try and make sure we confirm that we are trying to make sure that we communicate with members of the public in our communities that our broader range of services remain open for people who require urgent and other treatment. This is one of the complex issues that come from the pandemic, that we worry that people may hold back from accessing treatment when they need it. So a number of senior clinicians and managers are involved in setting messages and agreeing them so that we can continue to communicate our services are open. At this point, those are the key messages from me today, Chair. Thank you.
Thank you, Andrew. Okay, items 6 and 7 about the medicines management policy positions in 6 and development of some commissioning group policies in 7, both with you, Brent. We'll go through them separately, please. Do you want to take us through the medicines management first?
Yeah, certainly. Thank you, Chair. So these are the standing agenda item medicines management policy positions. For this meeting, there are 2 local policy positions that have been recommended by the Lancashire and South Cumbria Medicines Management Group. The removal of one because a medicine has had a licence removal, and then 2 NICE technology appraisals. I'll take the paper as read. There are the 2 local policy positions are medicines that have sort of long-standing, but there was queries in terms of the numbers of patients and the particular cohort of patients that should have access. I'd probably note the NICE technology appraisals, that there is one there which is inclisiran, which may have a not an immediate cost pressure into the system, but depending on uptake over the next couple of years, we're expecting that there may be cost pressures in the future as the price changes from a sort of an initial price to the standing price. So really just taking any questions in regards to those policy positions, or if people are happy to approve those as recommended in the paper.
Thank you, Brent. Debbie?
Thanks, David. It's just a clarification, Brent, if I could please. So I just noticed that in this first set of recommendations, in paragraph 1.3 on page 15, it says that part of the review process includes sort of assurance around patient engagement if it's sort of needed. So I know that there's no sort of patient feedback or views shared on this first lot, but there is on the second lot where there has been engagement. I just wanted to check what the criteria is for that not happening, and just to sort of get that assurance really about why it's different to the ones that come later.
Yeah, so the medicines policies historically have gone to sort of a public engagement process if there is if it's expected to have a significant impact or detriment to a patient population, then we would sort of go out usually via CCGs to patient engagement. The majority of the areas when we're considering medicines are opening up access to a new medicine. So usually with the medicines policies, they don't go for a routine public engagement unless when we do our screen at the beginning, we feel that there is a significant impact or patients may want to contribute to the decision. But generally we're opening up access, so it isn't a standard part of the medicines management process through Lancashire and South Cumbria Medicines Management Group.
Okay, brilliant. What would be really helpful is to stop me from asking you the same question at the next meeting. Could we be adding a line about why it wasn't relevant? Because it just means I get that assurance without having to sort of ask what criteria was applied. Yep,
perfect. We'll look to add that for the future papers.
Thanks, Brent.
Thanks, Debbie. Thanks, Brent. Right. Are we content to endorse the recommendation for the Medicines Management Group for this? Thank you. Yeah, brilliant. Thank you. Okay, Brent, second paper, please.
Yeah, and then the second paper relates to the outputs of the Commissioning Policy Development and Implementation Group. There are 4 policies today. One policy is an update to a pre-existing policy, which is the knee joint cavity. 2 of the policies which relate to urinary tract areas, so cystoscopy and benign prostatic hyperplasia, are new policy positions. However, they are based on the evidence-based interventions national phase 2 recommendations. And then one is a minor change to some wording in a policy that was approved recently. So again, taking the paper as read, the sort of the knee joint cavity, and we've highlighted the main significant changes. All of these policies, as Debbie sort of touched on, have gone through a clinician engagement process and then a public consultation process at the end of last year, and there were sort of no significant changes for any of the policies coming through those two processes. So just really whether anyone has any questions, or if people are happy to approve those policies as set out in the papers.
Thank you, Brent. Is there anybody else in this meeting, as a committee member, who is involved in this work as it builds up to come to here?
I don't think so in terms of policy position. Andy Curran is the chair of the Lancashire and South Cumbria Medicines Management Group. Okay, great. Andy, if you're there, anything you want to add, please, or just talk us a little bit through the process and how you feel that works.
Yeah, thank you, Chair. So if we look at them separately, Brent's explained about with the medicines group, we do go out to quite an extensive consultation through our heads of medicine optimisation in each CCG and into our acute trusts, and they will often bring in views from patients from specific user groups. So one example that members might be aware of is the use of ketamine. So using that, we've then had to specifically look at a group of patients who've been on high dose ketamine for pain for a prolonged period of time. So absolutely, Debbie, you're quite right that we need to be more explicit about when we are engaging with and when we're not, why we're not. As far as the clinical commissioning policies go, I don't have a direct role in this. However, they used to come through our Care Professionals Board. Now, within the Care Professionals Board, we used to make sure that everything that was coming was fit for clinical sign-off, recognising this is not a clinical committee and the place to discuss the clinical indications. What we did find, though, was that we had such assurance with the process that had gone through that the right clinicians were being involved with the discussions before it even came to Care Professionals Board. So just an hour ago, Lindsay, Peter and I met and we were discussing about this, saying we need assurance about the process. It should never come to us without having gone through that correct process and assurance. And so it's that checking to make sure that the process was right, not that the outcome was right, because none of us are experts on each of those, just even in this committee, on the conditions that come through. But what we have the assurance of is that the correct people who are experts and also non-experts from a generalist point of view have had the chance to comment on this before coming to us.
And are we satisfied about that, Andy?
Yes, I am.
Okay, thank you. Andrew?
Different point, if I may, Chair. One of the advantages of Brent bringing this over a period of time, the medicines policies and the commissioning policies, is that as we move towards the formation of the Integrated Care Board, we will have a common suite of consistent clinical approaches to this range of issues. So there's an action for me, I think, just to work with Andy and Brent to look at how we'll make that transitional from the CCG library to the ICB library of policy. We will do that in the early part of the new financial year. So I'd just like to keep that action there clear now, please.
Very helpful, Andrew. Thank you. Paul and Jeff.
Yeah, thank you. Really a question to Brent and more of a general question around consistency across the Northwest, Brent. And I just wondered how far you feel these policies are consistent with other areas like Merseyside and Manchester, particularly for patients who are, you know, using providers often outside, certainly in West Lancs, outside of Lancashire.
Yeah, thanks, Paul. So in the majority of areas, the policies align quite closely. One of the advantages that we have is that the work that's being supported for the policy development group is run through Midlands and Lancashire CSU, who I'm employed by, and they also support Cheshire and Mersey. So we have very good links into Cheshire and Mersey, and wherever possible are aligning policies to minimise those border issues. And certainly that is part of the process of development of all of the policies, is that we will look
Thanks, Brent. Jeff, then Andy.
Thanks, Chair. I don't think there's ever been a problem with accepting the recommendations from Brent and the medicines management machinery. I think it's high quality, and I don't think that's the issue really. I think these are good recommendations generally and evidence based. I think the problem for me is actually how well they are applied. And my experience back at home, back at base, is that clinicians don't always like to be told what to do. And we'll find a way around through exemptions and exceptions and wordings. A classic example from years ago, and I don't want to knock any one profession because we're all guilty of this, including myself. So, but just for way of example, when the new dementia drugs came out many years ago, they were for Alzheimer type dementia, and then all of a sudden, the descriptions of dementia coming out of dementia clinics started changing from vascular or Alzheimer's to mixed dementia, so that clinicians could prescribe these drugs perhaps when they weren't strictly in the guidelines. So I just wonder what mechanisms we are going to have as an ICB to try and ensure that people play ball with these recommendations. Thanks.
Thanks, Jeff. It's a good challenge. Andy, you can pick up your thoughts in response to Jeff as well.
Yeah, thank you. So coming in, Pauls, I would say that we're making commissioning decisions for our population and our population's needs. So just because another area has made a decision doesn't necessarily mean that we should. A lot of the policies, though, are based on best practice and evidence. So provided we're looking at the evidence, we may well come to similar outcomes, but I would suggest it's for this committee to set the thresholds. So there might be a cost benefit from one procedure that has a different threshold in different areas. We might also have to look at our population and say our population needs are that we have a particular group where we have a high incidence of one incidence or disease, and we need to make sure that we have appropriate access for that. So it's how local we wish to make it, and I'd suggest that as an ICB area, we then have the benefits to be able to do it. And that then leads on to Jeff's comment about the clinical policy and implementation group is about implementation and also the follow-up of what happens, who is following the rules and who is actually implementing. As separate CCGs, our medicines policies, for example, then go back for ratification in there. One big advantage for us as an ICB will that we will do it once and we'll do it across the system, and we'll then be able to look at who's implementing and who's not, so that we can then more closely hold each other to account between our place bases. So it will be quite a significant change to how we've done things in the past, but let's remember that's the benefit of us working more collaboratively and together. Thanks, Chair.
Thanks, Andy. Nicola?
Thank you, Chair. Yeah, just building on Jeff's point, really, one of the things that this committee will need to consider over this next 12 months is the governance for how we also consider clinical policies and compliance with service specification for those specialised services that are coming over into the ICS and other commissioned services as well in terms of some of the primary care. But we do know that one of the things that we have to monitor quite closely, and it's not always easy to do, is that compliance with clinical policies and service specifications. And occasional practice is quite common. As Jeff said, clinicians like to do things sometimes that we need to monitor quite closely and understand whether or not they're actually commissioned to undertake those services and have we got all of the right governance in place. So that will be something that we'll need to start to pick up, which currently sits regionally, and we're working with Peter Tinson and others to make sure that we've got that commissioning integration piece of work set up.
Thank you.
Just a note on specialised services, because I think that will be important.
Yeah, absolutely. Thank you. Jeff, did you want to come back?
No.
Okay, thank you. All right. So, no, it's fine. So the development of Lancashire and South Cumbria Clinical Missing Group policies. We've got the 4 policies there. Can we approve those, please? Thank you. Approved. Brent, well done. See you next time.
And, thank you for the very useful discussion as well, everyone.
Right, item 8, CCG close down report. Dennis, how's Mrs. Gitsy now? It's all okay?
Just about. I think I'm just about alive. If you'd have seen that, I think I'd have got a pan right back of my head. But apologies for my crappy spelling. Also, apologies, colleagues, for not having my camera on, because every time I turn it on, the signal goes. So you're going to have to do without my looking at my face a bit. So I'll crack on, Chair, if that's okay. What I'm going to do is, rather than go through the report necessarily, because I'm assuming colleagues will have read it, it's a pretty straightforward report. It's got some important things in there. I thought it better to just appraise the committee of the changes that we're going to have to take to the programme as a consequence of 2 material features. One of them is obviously the short delay to the inauguration of the Integrated Care Board, which is going to be July, and the other one is we've obviously had the operating guide issued to us on Christmas Eve. So there's been a number of meetings coming up to this one this week. So we've had the Transition Board, we've also had the Programme Board, and I've had lots of support from Helen, who's also on the meeting. She could go through any detail that we need as well. So I'm going to kick off with just 2 or 3 areas I think is pertinent to bring colleagues up to speed with. The primary one is the objective to get as many of the features of close down continued, operated on and cleared by the 1st of April. And that's important for a number of reasons, but one of them is that in the operating guide it clearly says in there that the integrated care boards will have to gear up for a state of readiness. And that state of readiness will require us in CCGs to manage the close down programme, clear off all the actions in there and get to a point where we can adequately and safely transfer many undertakings on the 1st of April. We clearly can't do all of them because some of the statutory features like finance arrangements, etc., will have to be contingent on the formal close down date. But I think colleagues in our finance system are well aware of that and are dealing with that. So it's really good practice to continue with the structured close down programme and a handover plan, despite the technical inauguration date being paused by 2 to 3 months. And that principle, I think, is supported by current RCS leadership. We've had conversations with Andrew, etc. Following on from that, we now need to do and undertake a full reconciliation of the current action plan and programme plan, look at all the objectives in the timeline, and also re-evaluate that and recalibrate it with the new operating guide for close down as we will expect to see from NHS England. It's not there yet, it's due out in a few days' time. So that's something we need to do. One of the things that comes with that is to differentiate the actions that we can do now and we can quite easily and safely complete, and it won't need duplicating after the 1st of April, and those that can't. So I'm operating on the basis of 8 and 80-20 rule. Probably 80% of the features in the action plan can be safely transferred on the 1st of April, leaving 20% of the more technical governance and legal and financial requirements requiring a little bit more work to do between April and July. But we'll do that reconciliation and make sure that this committee is up to speed and we bring that back into due course. The risk assessment and the risk logs also need to be refreshed, particularly in areas that relate mainly to staff. We've had a number of conversations about this over the last couple of days, and I think it's accurate to say, probably safe to say, that there's been a little bit of a, well, I would say a little bit of a sea change in staff anxiety levels since we came back after Christmas. But I guess that statement doesn't make a great deal of sense. But I think it's pretty sensible to say there has been a noticeable sea change in the anxiety levels of staff, and that's anticipated. It's when we go through these processes, in particularly in the new year, But we need to keep a really close eye on that, keep people close to us, have a really good communication system. And this, I'm not talking about just CCG staff, I'm talking about all of our colleagues connected into this change, our lay members, our executive colleagues, our GP colleagues, and obviously our core staff. Further on than that, we've also got, we know we've got a temporary pause to the creation of the formal RCB operating arrangement, but the programme will now need to determine as soon as humanly possible how the system will operate between April and July. I won't steal Andrew's thunder because we're going to cover some of that topic, well, a great deal of that topic later on. But what I'm going to suggest or recommend to the committee is that this does require some further clarity around some delegation of arrangements and some leadership arrangements between the designate RCB, the designate RCB executive, and the designate place executive and place teams. So I'm going to work closely with Andrew and colleagues to work out the best way to do that, because it does fit very neatly into the close down programme, and it's something I think we need to have in place as quickly as possible. Just coming up to the final 2 points now, Chair. Via Mersey Internal Audit, we're working closely with Keith Bowman. He's notified us that and the group, the NHS England and Improvements, are currently refreshing the National Close Down Critical Path. He and Jane will share that with us so we can do the recalibration exercise. We're all keyed in together, we're working closely on that. And the final point is Jane Cass very helpfully also confirmed and endorsed the original opinion, which was our primary objective should be to carry on with the close down programme. We should not delay, we should only take account of the technical arrangements that cannot be closed down before April. So she's confirmed that to us as well. So at that point, Chair, I'll hand back over to you. You might want to invite, not telling you what to do, but Helen might want to add some technical thoughts to it, or might not want to, but that's my report over and done with. Thank you, Chair.
Thanks, Dennis. Helen, anything you wish to add?
I think perhaps, Chair, just to say that in the conversations that we've had since coming back in the new year with colleagues who are working on this, so that's, I have a governance working group of the heads of corporate within each of the CCGs. There's very much a focus on cracking on with this work. No hint or ask for any delay, because I think it's when you stop something and then try and start again, it's even harder. And I think the other reason for that is the staffing issue, because the longer this goes on, it brings up the issue of resilience amongst our staff. So I think that absolute commitment. But what I do think we need to do is think about how we bring some groups of staff together in order to ensure that we succeed at both close down and the establishment of the new ICB. We have some thoughts on that, and I think they're brought into Andrew's paper that we're going to discuss later. So other than that, nothing further to add, Chair.
Thanks, Helen. Quick thoughts, please. Roy, then Graham, then Paul.
Well, in terms of expediency, Chair, I won't add anything to that. I'll bring something into the conversation later on, if that's okay. Thanks.
Graham, anything you want to add at this point?
No, I think like Roy, I've got some concerns, but that's maybe we can deal with them from the Andrew's item, perhaps.
Thank you, Paul.
Just to add, there was a meeting this morning with the national team around some of the financial issues, because they're obviously quite difficult with the extra 3 months. So one of the things that was discussed, which is more about setup than close down, was how we split off allocations for 3 months from the ICB, which I won't go into, which is quite technical, but that will come out soon. And the other one, which everyone's wrestling with, is the audit of the 3 months after the CCG's finished. So that's going to be something that we need to. It's in a very difficult to-do box at the moment, given the audit support that we need. So there are discussions nationally and regionally with the audit firms at the moment to see how we resolve that, because that's at the time of year as well where we'll be looking to set everything up as well. So we need to retain staff in the system to do the accounts, but also to answer the audit queries. So I just wanted to update on that.
Thanks, Paul. Debbie, and then last word on this for Andrew.
Thanks, David. Thanks to Helen and Dennis for the paper and the thoroughness of the work and the assurance that's in it. Found that really helpful. Dennis sort of touched on it already, but I was just going to make the point to reinforce the importance around clear comms on this and the change. And they're important anyway, but particularly when there's a change, there's a lot of interested groups like the public, like lay members, like ICP staff, local authority partners and other stakeholders for whom this is really interesting, and they'll have questions around it. So it's just to sort of make that point. I'm sure you're on with some kind of comms strategy, but we just need to be really conscious of it at each change and generally. So really practical things like the paper that's come here in public, could we have maybe an enhanced version of it that could go through to CCG boards just to support some consistent messaging in a public domain about the changes and implications?
Thanks, Debbie. Andrew.
Yes, again, so thanks for the paper, Dennis and Helen. And actually, what sits behind the paper is a really structured programme and commitment to doing this. This change in timeline does bring some complexity and risk, and as we're saying, we need to work through some of that in the course of the next few weeks. We are expecting some helpful additional guidance within the next few days, as Dennis says, and I think again that will inform the dialogue with governing bodies, with chairs and lay members, as a number of you are suggesting. We do, of course, in Lancashire and South Cumbria have the benefit of this significant history of collaborative working and intend to use SCC as a significant forum for progressing collective decision making over this period, both in terms of reporting progress, managing risk, and also helping the ICB begin to work in shadow and then become a statutory body in its own right. Very much endorse Debbie's comments about communication. We have an initial briefing for stakeholders that's prepared for David and I to sign off, Debbie. Perhaps Dennis and Helen could pick up your suggestion about the value of this board paper being shared more broadly across other governing bodies, because clearly one of the things that exec leads are doing is trying to agree the management of business through governing bodies in Q4 at this stage. We also have two all staff briefing sessions next week. Now, again, we're conscious of the fact that people are very much engaged in their operational responsibilities at the moment. We did feel it was critical to have some time, probably just with some core messages and an opportunity for an initial Q&A, but then I suspect planning some further briefing when the pandemic has just receded somewhat. So again, a commitment to you around general communications. Thank you, Chair.
You're on mute, David.
Last word back to you, Roy. Thank you.
Okay, thanks. Just to answer Debbie's question, at the Transition Board in December, I asked that a paper be prepared for January for CCG boards, both an overarching paper on the current position with regards to establishment of the ICB, which I've signed off this week, and I'm aware that Helen is doing a more comprehensive paper, I think, on close down of CCGs. Again, that will be a generic paper that will be available, I think, to all CCGs, I think probably later this month. Helen, am I correct to say that?
Yes, Roy, we're going to just make sure that we incorporate the latest guidance that comes out so it's as up to date as possible. Thank you.
Thank you.
Great. OK. It's a huge challenge, and the complexity that a number of you have highlighted we'll need to work through in a very sure-footed and careful way together. But I think that we've certainly got all the things on the to-do list that need to be there, and it's a good paper. And thank you, Dennis, and thank you, Helen. And we'll stick close with this as over the coming weeks and months. So, quality and performance report. Catherine or Roger, please.
Thank you, Chair. I'll start off and hand over to Catherine. I'll take the paper as read and just pick out one or two performance metrics from each of the sections. The performance report reflects the extreme pressures services are under and have been under for some time, and it's in this context a remarkable reflection of the whole system. Section 3, November A&E performance against the 4-hour target was 74.7% and is now cumulatively 78.7%. Activity numbers and acuity remain high in November. There's been also a high number of 12-hour waits in A&E, reflecting the pressures both in and out of hospital. The October position for cancer, referrals in the system remain above pre-pandemic levels, and there are significant increases in referrals for breast, colorectal, head and neck and gynae. Against the constitutional targets, there's been a deterioration in the Alliance rankings for 2-week waits due to pressures particularly in breast and skin. Section 5 has the diagnostics for the 4 acute trusts, and this is a more positive position in October, with the size of the waiting list reducing and patients being seen within 6 weeks also improving. The community diagnostic centres have supported this improvement. Section 6, elective care. October had the most GP appointments reported per working day for the last 31 months. The increase in appointments has also been in face-to-face, with non-face-to-face remaining steady. CCG commissioned activity in October had recovery rates of 87% for admitted and around 100% for non-admitted. And a snapshot of our providers in December remained at 87% for admitted and close to 100% for non-admitted, which is a remarkable achievement in the circumstances. The system waiting list is now over 166,000 in October, and 69% are being seen within the 18-week standard. We've got 9,442 people waiting over 52 weeks at the end of October, of which 753 are waiting over 104 weeks. I'll hand over to Catherine now, Chair, if that's okay.
Thanks, Catherine.
Thank you. Again, I will take the paper as read, just to pull committee to a number of issues. As we've seen, the pressure continues across all sectors, and staff absence is running at 50% higher than it was just 2 weeks ago. The acute providers, our local authority colleagues, regulated care sector are all currently training non-clinical staff to deliver and undertake those caring tasks under supervision. PCN groupings within our CCGs are working together across those groupings to share staff so that practices can continue to function. And as Roger has just stated, that is working in generating those appointments, either face-to-face or virtually, which I think across the system is a fantastic achievement in the current circumstances. We can see that through working with our local authorities that our regulated care sector is under significant pressure. We have 80% of our providers who are currently within outbreak. So we have far more in outbreak than out. We are working very, very closely with our local authorities, particularly with residential care settings, to try and ensure that that care is maintained at a level that is appropriate and that omissions of care are kept very minimal. So again, that is bringing all teams together, both health, social care and our voluntary sector organisations, to ensure, and we continue to work with our regulators, with both CQC, to ensure that that delivery can continue in the best way possible. The vaccination programme is continuing full steam ahead, and thank you to all those staff who have been mobilised and stepped into this very quickly pre-Christmas. So the modelling of this continues across the whole sectors, including the mass sites, and now we are looking at mobilising that programme so that we can go out and target specific populations using both pop-up sites, mobile testing units, as well as vaccination programme. What we are seeing through some of those pilot sites, so we have a drive-through vaccination site, which is our first in Lancashire and South Cumbria at Ewood Park. And we are seeing a lot of people going through there having their first dose of vaccine. And those figures are very, very good. So it's not incredibly busy. There's a steady stream of the public, but we are seeing a high percentage of that run through on first vaccine, which is a model that we need to replicate. You will all know we do have a risk in relation to vaccination and the mandate that both health and social care staff all have to be fully vaccinated by the 1st of April. That means that the first vaccination, if people have had none, needs to have happened by the 3rd of February, so very quickly. We're working across the system to gather all of that data so we know if we've got hotspots anywhere and how we can work with those individuals. There's a lot of activity and all professions are included in that. So there's doctors, nurses, paramedics, our reception staff, a whole host of staff. We are looking at those percentages, looking at those hotspots and trying to mitigate those risks before those deadlines and to ensure that that vaccine availability is there as and when people are ready to take that up. From our deprivation of liberty, I just need to escalate. You'll note in the report that there is just a sentence on that. The escalation at the moment is that we do have a delay in our deprivation of liberties of 335 cases. 21 of those are in the Blackpool Authority. Triage has commenced on those and 13 are currently triggered at a red risk, which means they are very high in terms of restricted practice. Those are currently being managed as I'm reporting now. So the risk is known, it is being mitigated. Extra staff have been brought in to ensure that those deprivation of liberties are being dealt with. That will be reported as an urgent through the IPA boards and through the safeguarding boards. So I felt it's important that we flag that into here now as the numbers are known. So those are the key escalations and I'm happy to take any questions. Thank you.
Thanks, Catherine. Thanks, Roger. I mean, this is a very stark picture of the service under incredible pressure. Nicola.
Thank you ever so much, and thank you, Catherine. It was just to add, I should probably just let the board be aware that I've, while still here representing NHS England commissioning, as Andrew was saying earlier, many people have been redeployed to help with the pressures that the system is facing, and I'm very fortunate and privileged to be acting as Director of Vaccine Inequalities at the moment for Lancashire and South Cumbria. And I just wanted to add a little bit to what Catherine was saying though. She says the drive-through at Ewood Park, fantastic uptake. I think on the first day, about 36 of the vaccines was for people with the first vaccination, which is great because we currently have around 25 local authority wards where our vaccination rates mean that we've got about 30% of the population who have not been vaccinated in some of those small communities. And just to add that we're putting on buses this Friday and Saturday in part of Pendle, just as one example, and just to thank everybody in the system that's been involved, because the response from local authorities, from community leaders, to make sure that we do all of the engagement this week has been absolutely phenomenal and mobilised in a very short time. So just wanted to add that in, that we have got that real focus on inequalities that I think is really, really important to make sure that we're protecting everybody and reducing hospital admissions around vaccination.
Thanks, Nicola. Debbie.
Thanks for that. I know obviously we're short on time, but there's a few areas that would be really helpful to just have either a little bit more information or a bit more assurance, either in the meeting or outside. Sort of happy to cover sort of in whatever way makes most sense. So if I rattle through them quickly, and we can sort of judge what's best. The first sort of question that I had was around the friends and family test, just from a patient involvement perspective. So it's 3.7 on page 54. So it just draws attention to the the outcomes from the recent Friends and Family test, which is obviously a really good way to see patients' view of how things are working. And it does mention that Royal Preston Hospital is a bit of an outlier in our area where there's a difference and lower levels in satisfaction. So I just wanted to sort of understand really how that's being considered, if we know what that might be at the moment, or if there's anything that we need to think about sort of together to be able to support that. The second one was about advice and guidance and the model for referrals that's being rolled out to support the system to better respond under 6.1.8. So it was helpful to get some information around that. And I just wondered how patient feedback's being gathered or considered as part of the initial tranche to influence and guide what we do when we actually roll that out bigger and better. And then the final, there was a few around sections 10 to 12 around sort of the mental health and learning disability section. So thanks so much to Catherine and Fleur, because they've taken on board feedback for a little bit more detail and consistent data, which was brilliant. But I just think that there's some quite significant ongoing issues raised around access to services. So 11.4, huge increases around eating disorder continue. We're doing some things, but I'd really welcome some more assurance around the detail there, because I'm concerned it's not making the difference or getting the traction that we expect, and that we maybe need to think together through the SCC around more commissioning or different decisions to be able to get the difference that we want. And then similarly, there's an ongoing issue around access to autism services and community provision not being there, and the pressure it's putting on the acute system. And again, it's kind of saying this is something that's ongoing. We're doing the same things we were doing last time. We don't seem to be making the difference. Is there something else we need to think about that's more innovative, more different, that needs to come back to SCC to address this?
Thanks, Debbie. A number of points. Now, I think that all the points you raise require a more substantial response and discussion, actually. And so I would ask, rather than sort of risk getting into anecdotes and perspectives from a distance, if Catherine and Roger could produce a further report delving into these issues more, we can circulate it to all members of the board as soon as it's ready, address it to Debbie, and then you can have a dialogue outside of the meeting, Debbie, and then we can agenda these items for a proper discussion next time, if that's okay.
Yeah, absolutely. Thanks, David. I know it's time pressure. That's a great.
Yeah, no, I just don't want to miss important things because we feel we have to rush, and I think that in these ones you've raised, that's the best way of dealing with them. So thank you for that. Okay, any more questions on this report? Thank you. Again, Roger and Catherine. Now, the special educational needs update, please. I don't know if this is Julie or Hilary.
Hi, thank you. I'm going to introduce and then through the chair hand over to Zoe Richardson. As colleagues will be aware, we did have a very difficult Ofsted CQC assessment in 2017 and have worked together as a partnership through the SEND Partnership Board to address those issues. We've got some really positive news to share in that due to this successful work, we are no longer in the DFE oversight process. So that was our first message. I think this tribute to the SEND board partners' leadership with Edwina Grant, particularly Hilary Fordham and also Zoe Richards, who will present the paper. The second part of the paper that we want to set out is the commissioning intentions that we had in place to get through the oversight process, shall we say, and also that are required for us to continue to deliver our SEND plan. And autism is part of that, so that will come through. And then there's a description of what we are going to see in relation to SEND assessments in different areas of Lancashire and South Cumbria. So through the chair, if I could hand over to Zoe, she's going to give a short presentation to take the board through those issues.
Thanks
Zoe, over to you.
Thank you. So if I can just share, it is a short presentation, and I'm very conscious of the fact that you have limited time today, so I will keep it brief. So, sorry, is my microphone sounding funny for you all?
Yes.
All right, let me take, because I could hear some sound coming back from me. Hopefully that's better.
It is.
Good. So first of all, you've got a copy of the paper. I think it starts on page 107 of your documents today. And alongside that, you have an additional document as well, which is the Send News. It is the first of our new Send News that we'll be sharing now on a monthly basis, so that you have got an update of what's going on across the ICS with Send. So if you want to understand our current roadmap, priorities and the principles that underpin the work we're doing, that is in that copy of the Send News. So for today, I want to give you a very brief update. First of all, NHS England now require us to produce a Send maturity matrix. I've returned the first return for Q2, and the second return I've just sent in for Q3. The next one is due in April. With the first return, we have received the feedback that we're one of only 2 areas in the country that are identified as green, and we're recognised as having a coordinated and organised approach to Send. And in fact, in talking to Lorraine Mulroney, who is the National Send lead, she has informed me that she is wanting us to showcase how the ICS is working with Send and the Send leadership to other areas of the country because of the work that we've been doing here. It is recognised that part of that might be to do with the council structures that we have in this area, but also it is recognised the work that we have done over the last 4 years as well. So then an update in terms of each of the individual areas. Blackburn with Darwin continues to progress well on the ongoing improvements. It didn't receive any improvement letter or written statement of action, which was good back in 2019. And as a result, we were invited to, I will say volunteer, but I think you can probably put that into inverted commas, to be a test area for methodology testing of the new Send inspection framework. That happened in November. There is significant learning from that and really valuable learning. One of the main points being that there is going to be a shift into providers being the main area of future inspections. So one of the pieces of work we will need to do as a new ICB will be about inspection readiness for our providers. I have started some of that work already, but we will need to do more around that. There will be more learning around the methodology testing. We've had a meeting today and there's a further meeting for us to make sure that we are gathering that learning together. Blackpool has yet to have its initial inspection. We did expect it before Christmas. It's not yet happened, so we now expect it before the end of March. And that's because in theory, the new Send inspection framework starts from the 1st of April. Learning's being taken from other areas and progress is being made, but we do think that there is more work to do that might result in either an improvement letter or a written statement of action. Cumbria has had an inspection in 2019 and awaits the inspection revisit. Again, we expected that before Christmas, so we would now think that will be sometime before the end of March. We do know that we've got 3 areas which we've put in place accelerated progress plans for that we don't expect to be passing. So we would expect that the inspectors will say there is a requirement for an accelerated progress plan. Those are in terms of strengths and weaknesses in performance, ASD, as we had happen with Lancashire, and transitions as well, again, as we had in Lancashire. So it's no surprise that they are recurring themes, and in fact, they are recurring themes across the country. Lancashire, as Julie mentioned, the Department for Education and NHS England have had their final review of the evidence. We were informed, by the way, that our evidence pack is the best evidence pack that they have ever received. So I think that's really strong for us all. We did work very strongly as a whole team towards putting together a strong evidence pack, and we were able to work as a partnership in delivering the information for the monitoring. Debbie, who's with us today, has also been very strong. I was trying to find a different word for it there, Debbie, because it was a bit more than strong, very forward driving us around the check and challenge of the work that we did. And we did make changes as a result of the way that Debbie did the check and challenge on your behalf. So we really do value that support that we had. We have been informed, though, that should progress not be continued, should we fall backwards or not continue to carry on with our progress, monitoring will be re-established. So although we've been released, it's not a blanket release. We could be put back into monitoring. So I thought you'd find it helpful, and this also links in with the investment for the future as well, for you to see the risks and issues we have continuing for SEND. The first is making sure that we have the right positioning for SEND and the right links with the ICB resources as we go forward into our new architecture. The second is one of our areas that we do require investment, ongoing investment for, which is the ASD waiting times. We received half of the funding and we're able to do a proportion of the work that we needed to do, but we still have significant more work to do around waiting times for ASD. And the move into the ND pathway, which was agreed in 2018. A paper should have gone to Collaborative Commissioning Advisory Group in December and again this month, but unfortunately that's been stood down. So we haven't yet had a decision made around the funding for ASD and ND. We did have agreement around the specialist community nursing services, but have yet to have a funding framework, so we still await that. So both of those areas of work are areas where we need to make sure that we don't miss out of the planning process that goes on. We still have work to do in terms of transitions in healthcare. We've moved on significantly with that. However, we know that we've still got more work to do to make sure that we are fully engaging adult services. And we've given ourselves a 4-year plan to make sure that we deliver in its entirety. And then the final issue is relating to capacity, which of course will go back into the funding context. We are one of the most under-resourced areas for our designated clinical officers. So the fact that we have managed to achieve so much and do so well with our education healthcare plans with the support of our DCOs is a credit to them, because we are so significantly under capacity compared to other areas. We also need to make sure that as we move into the new architecture, that we remember that much of the project delivery for SEND is delivered through matrix management structure with our commissioners, and that can't be missed as we move forward into our new architecture, because it's crucial for how we deliver the work on SEND. So a reminder of the recommendations, and obviously within these recommendations there's also the context that we have got to make sure that we position SEND well for the future ICB, but also that we retain that positioning with local authorities, because local authorities retain the statutory responsibility for SEND, and the SEND partnership boards for each of the local areas obviously holds that responsibility on behalf of the local authority and health services. So we do need to make sure that we do continue to work as we are doing, whilst also supporting future architecture for SEND in the ICB. So I'd ask you to note the outcome for Lancashire's Accelerated Progress Plan, to continue to support the funding requests, and to recognise that there will be further developments coming forward through CCAG over the next few months. And I will leave it there and answer any questions if there are any.
Thanks, Zoe. Thanks, Julie. It's very clear, and it's very clear the real progress that's been made, and thanks and congratulations to you guys and to the team working with you on this. Andrew, can you just help me a bit on the governance on the funding question here? Is this something that we will pick up formally as part of the planning process for next year, or something to deal separately?
Yes, I think so, David. I think we need to direct it through that. And we've had the national planning guidance, but we haven't yet kicked off the formalities of the process. I'll liaise with Julie and Zoe outside the room to make sure that those issues that she's just raised are fully understood, but they will need to be factored in as part of the planning process. Thank you.
Okay, thank you. But on that, Zoe, though, be optimistic about the outcome of that. I just want to make sure that we get the process right and proper alongside everything else. Any other questions for Zoe or Julie? Okay, thank you. Excellent work. Thank you very much for providing the update and a very good presentation.
Thanks very much.
We'll receive the reports from the CCG Transition Board, Andrew, and from the Quality and Performance Subcommittee, Catherine. Thank you. I've not been notified of any items of any other business, so I'll bring this formal meeting to a close now. Our next formal meeting's in March, the 10th of March. I look forward to seeing then hopefully some of the pressures that we've been discussing today will have alleviated a bit by then, and we can have a more in-depth discussion about some of the key issues we've not done enough justice to today. So thank you. This is the end of the meeting. For those involved in a part 2 meeting, we'll sign into that in 1 minute's time. Thank you very much.